All right. Good afternoon. The recording has begun. My name is Mary Franzen. This is the February meeting of the Universal Healthcare Commission. Once again, as our commission members arrive, you will be offered a little pop-up box to be promoted to panelists. Please accept that, and then you'll be able to unmute yourself and speak during the meeting. And now I'm going to turn it over to Chair Vicky Lowe, who can call our meeting to order.
Hi, Tonga. Good afternoon. Welcome, commission members and members of the public and staff. It is now 2:03, and I call the February 12th meeting of the Universal Healthcare Commission to order. I would like to give a warm welcome to everyone joining us for today's meeting of the Universal Healthcare Commission. And also I want to thank Pam McEwen for coming back and stepping back into the role of the liaison between the commission and the Financial Technical Advisory Committee, or FTAC as they're more commonly known. We look forward to working with you to align the work of the commission and the FTAC and appreciate your time doing that. Mary, can you please do the roll call?
Sure. Thanks, Vicky. Chair Vicky Lowe.
Present.
Joan Altman. Joan Altman. Jane Beyer. Jane. Okay. Nicole Gomez. Nicole let us know that she might be joining late today. Dave Eisminger. Dave let us know that he was not able to attend today. Dr. Tao Kwan-Get.
Present.
Badisha Mandal. Badisha. Representative Lisa Parsley. She also let us know she was not able to attend today. Omar.
Present. Good afternoon.
Good afternoon. Representative Joe Schmick. Okay, Representative Schmick. And Mohammed Shidani.
Hi, Mary. Thank you very much. I'm here.
Oh, hi, Mohammed. Okay. I count 4 people so far. Well, some folks may be arriving late, but that we do not have a quorum.
All right. So we'll skip the vote because we don't have a quorum. But that makes us early for public comment by 5 minutes. Do you think that's a problem?
Technically, we should make sure that we're still having public comment period during that time. So maybe if folks are willing, we could have the minutes, and if anyone sees any issues or anything that we should correct before the next meeting, we could do that because we don't have a quorum as noted, so we won't be able to take a formal vote. But certainly if anyone has any comments or questions related to the minutes, we could address those.
And that's the risk of having a meeting during session, right? I'm sure everybody else is over at the Capitol.
And also, I would like to note that I see Badisha Mandal has joined. So, Badisha.
We might get it.
Hi, can you guys hear me?
Yep.
Yes.
Oh, okay, thank you.
Okay,
My
now
Zoom was giving me some trouble, so I was late, sorry.
All right, thank you.
So here are the meeting minutes from our December meeting. They're being scrolled through. They're in I think the second tab of your meeting notes. Are there any discussions about the minutes? Did anybody see anything that needed to be corrected? Right. then I guess we'll table that and hopefully more members will show up and we can get to a quorum. How many do we need for a quorum, Mary Ross?
7.
7.
And I
So
think we'll
get
I
there.
apologize, Chair Lowe.
No,
I think we're
It's
okay
fine.
to move to public comment, as long as public comment is scheduled to begin at 2:10, as long as we go past that 2:10 mark. My understanding is that requirement is to ensure that public comment isn't conducted prior to the publicly noticed time so that someone would miss their opportunity. So I think as long as we're continuing past that start date, we should be okay. So it's a long way of saying I think we can get started with public comment.
All right. Thanks, Ross. All right. Since our last meeting, we received a number of public comments. These comments included support for our mission and encouragement to keep working towards our goal. We received some personal stories about struggles with the current healthcare system and feedback about provider reimbursement principles currently being developed by the Financial Technical Advisory Committee. Commission members received these public comments as part of their full meeting packet for review. Individuals may also provide public comment during the meeting, and we will hear from them now. So for those online, please use the Zoom feature to raise your hand. I think is there a list of people who have signed up already, Mary?
Yep, we have 5 people
Okay.
who have signed up ahead of time.
Okay, and so you'll call those off
we'll
and
do
then
those.
we'll take people with raised hands after that.
And our first person, and it's, please say your name and your affiliation, and it will be 90 seconds for your comment. And the first person who signed up is Sherry McAvoy.
Hi. Are you able to see me?
Yes.
Okay. My name is Sherry McAvoy. I'm a volunteer with Healthcare for All Washington and Whole Washington. And I've been an RN since the 1980s during the HIV/AIDS epidemic, and then for the last 28 years as a family nurse practitioner. And I've seen what untreated preventable and untreated other infections and diseases, how they affect patients, families, and friends. It's devastating to have a serious or chronic illness, and really as a nation unforgivable for a country to deny preventative care paid to citizens and residents. The fact that 60% of bankruptcies are related to medical debt and illness. As a commission, you must get universal health care to Washington State. I hear that that's your mission, and it really is a critical mass right now. With a Democratic trifecta and the social energy behind these horrible cuts to our health care, I implore you to act and bring these bills for universal health care up to the legislature with the help of these excellent agencies. Whole Washington and Healthcare for All Washington are both experts in the field. They've researched it forever, and I encourage you to please reach out and let's push it forward, because we haven't made action since this commission has been involved, as far as I can tell. Thank you.
Thank you. Before we go to our next speaker, I'd like to pause and go back to the roll because Jane has joined us. So Jane Byer.
Yes, I am.
Okay.
Sorry.
Yes, we noted that about many of the people here today. The next person who signed up is in the room with us, and that
And
is.
Mary, this is Joan from the Exchange. Just wanted to say hi as well.
Oh, hi,
So
Joan.
I snuck in as well. Thanks.
All right, I think we have we hit our quorum? Okay, we've hit the quorum. Should we continue with public comments and go back? Okay, so we will continue with public comments and then we'll go back to voting on the meeting minutes. The next person who signed up is here with us in person, and it's Eowyn Grubbs.
My name is Eowyn Grubbs. I live in Olympia and I am chronically ill and disabled. I want to personally thank you all for the critical work you're doing to turn the idea of public universal health care into a reality. Managing a chronic illness is a full-time job. Managing our broken healthcare system has become an unfortunate side hustle. My condition is genetic. I have had it my entire life, but was only diagnosed as an adult. Growing up, my family didn't have health insurance, so my condition was only ever treated as acute episodes. I was treated by my pediatrician, the ER, or hospitalized, but never sent to specialists who could have connected the dots. If I'd had access to treatments as a child and young adult, I may have been able to slow the progression of my disease. As it is, I'm now unable to work. I'm a recipient of Medicaid and I'm working on getting approved for disability. But it's a long, difficult process. I'm terrified that if I don't get approved before the Medicaid expansion work requirements go into effect, I'll lose what quality of life I still have. Medicaid covers thousands of dollars every month in medications and treatments. It paid for my wheelchair. I have an amazing team of doctors and specialists, family and friends to help me with transportation, housing, activities of daily living, and emotional support. I have so much more than many in my position, and still I have to wonder how my life would be different if I'd had access to health care as a human right from birth. Please keep myself and others like me in the forefront of your mind as you do this important work. Thank you.
Thank you for joining us. The next person who has signed up ahead of time is Lindsay Nickel. Lindsay, I think you can unmute yourself.
Yes, I am here. Can you see me and hear me?
Yes.
Awesome. Hi, my name is Lindsay Nickel, and I am a licensed mental health therapist in Gig Harbor. I'm also a volunteer with Whole Washington. I am grateful for the commission and want to recognize your hard work, so thank you. I'm here today to express my support of universal health care and also to represent all of my clients who have expressed their desire and need for better health care in Washington state. Opponents of universal health care would have us believe that this hellscape of expensive, rationed, and fraudulent care is an inevitable outcome of any past legislation. And not to let the facts interrupt that great story, but the US has already successfully run many types of universal health care, from the Veterans Health Administration to Medicaid and Medicare. And we have run these effectively and compassionately for over a century. It's only with the advent of privatization and deregulation that our universal healthcare systems have started to collapse. High costs, waste, fraud, overbilling, and abuse of the tax code by the wealthy have created a situation in which many Washingtonians simply cannot afford their healthcare and self-ration out of the system. They, in fact, choose to go without instead of going broke. Washington state can return to a time before we allowed corporations to train us how to be bad citizens. Universal healthcare makes moral sense, it makes ethical sense, and it makes big financial sense. And I really thank you for your help in making this possible.
Thank you.
Mhm.
The next person who signed up is Jane Grafton.
Good afternoon, members of the commission. My name is Jane Grafton, and I'm a recently retired public health research analyst, and I've had the good fortune of working for an employer for 40 years who provided health care for me and my family at a negligible cost. And I've been a lifelong advocate for universal health care. Today, I ask the commission to advocate for a legislative work session for the Washington Health Trust. I ask that the FTAC, when determining how best to use the OIC proviso, consider a financial analysis, how the system will be financed, and what consumers will pay out of pocket, using the Washington Health Trust as a model. I hope that the outcome of the OIC proviso expenditure is an implementable recommendation that the commission can act upon quickly. It's time to go beyond transitional solutions and focus energy on bold steps to move forward towards publicly financed universal health care for all Washington residents. Let's meet or beat the WHO deadline of 2030 for universal health care. Thank you.
Thank you for your comments. Next, we have Maureen Brinkland.
Good afternoon. Hi, my name is Maureen Brinkland, and today I'm speaking for a subcommittee of healthcare as a human right, and we affectionately call our subcommittee HUCS. It's made up of a group of healthcare advocates, and I made this same comment on behalf of HUCS last week at the FTAC meeting, and we met this week and decided we should make it again for the Universal Healthcare Commission because it's on your agenda as well under tab 6. HUCS members strongly recommend the highest priority of the OIC funds to be made for UHCC to hire the most qualified consultant who can study options for financing the universal healthcare system. By financing, we mean an economic analysis. How will the universal healthcare system be paid for? For actuarial analysis, there are several existing that the consultants could make use of, including those provided by the Universal Healthcare Work Group and by the Washington State Health Trust. The questions the study could model are what are the funding sources and funding levels that could generate enough money to pay for the healthcare provided to Washington residents, and what is the estimated range of how much individual Washington residents will pay per year individually, not in aggregate, to fund a new universal healthcare system? How does the estimated cost to individuals compare with what individuals currently pay, keeping in mind that we're already paying for healthcare, but we're paying it the least economical, least rational, and least efficient way possible? I'd also like to mention an article in Health Affairs that was published this week called Time for State-Based Single Payer, the New York Health Act. Thank you. And thanks for your work. At HUCS, we all want to thank you.
Thank you. Okay, now we can open it up to folks who put up their hands. I'm going to turn to the people who are in the room with us to see if anyone would like to make a comment. Okay, then we'll go to the virtual hands that are being raised online, and I think Thomas Kennedy is our next person.
All right. Hello, my name is Thomas Kennedy. I'm a volunteer with Whole Washington, and I actively work on our policy team. I want to thank this commission for all of the excellent work they have done over the past several years. This commission has made great progress, but there's much more to do. Our healthcare system is in crisis. Earlier today, I was at the Healthcare Defense Unity table, and it was stated that we need every funding bill to go through to keep our system funded as it is. Our governor sent out a tweet yesterday saying 19,000 fewer people signed up in the exchange. Premiums are doubling or even more for many of our residents. Now is a time of urgency. It is a time of crisis. The HCA will have to dedicate a lot of its resources to dealing with work requirements and other draconian federal cuts. We have to do something big, and we have to do it together. HCA, OIC, advocacy organizations, the Universal Healthcare Commission, and legislators need to work together to protect Washingtonians. The simplest answer to all these problems is not to play whack-a-mole as all these problems arise, but instead to go on the offensive and establish universal healthcare. The Washington Health Trust is one way this can work. Us advocates don't care much about the specifics, but we do care about action. Action from government bodies and the legislature. We will continue our legislative development with Senator Hasagawa in 2026. I hope we can work with members of the commission to help increase support for the commission and achieve universal health care by 2030. Thank you.
Thank you. We have one more hand up. Judging by the login name, I'm guessing your first name is Stephen. Yeah, let's see if I can promote you. All right, I'm not sure. Let me give, it's Fieldwave Stephen, I believe. Let me give it one more try and then we can come back to you. If we get the invitation to be a panelist, please accept. There we go. If you can unmute yourself, we'll be able to hear your comment.
I am really sorry. Can you hear me now?
Yes, we can. Thank you.
All right, thank you. Anyways, my name is Stephen Field and I live in Federal Way. In healthcare, I'm classified as a DSNP enrollee. The fact that most people can't define that acronym, which stands for Dual Eligible Special Needs Plan, illustrates the core problem. Our system starts with a complex nomenclature and ends with a landscape that is nearly impossible to navigate. The current special needs framework often creates more barriers than it solves. We must shift towards comprehensive residency-based coverage via the Washington Health Trust to end the cycle of churn. Currently, every time a Washingtonian changes job or receives a small raise, they are forced to re-enroll, change doctors, or lose coverage. This fragmentation hurts patients and creates a massive administrative tax on our providers. To solve this, Washington must integrate state data silos to create a seamless enrollment portal built on 3 pillars. 1, automatic enrollment. Issue a single Washington health card to every resident. 2, permanent status. Eliminate open enrollment barriers and renewal paperwork. 3, ensure this pathway covers all residents regardless of immigrant status and unified financing. I urge the Commission to recommend a system where healthcare is a public utility available to everyone from day one. Let's move away from the alphabet soup of confusing plans toward a system built for the people it serves. Thank you very much.
Thank you. The next hand up is Catherine Lewandowski.
Hi, everyone. Can you hear me?
Yes.
Okay. Yeah, my name is Catherine Lewandowski. I live in Arlington, Washington, semi-retired registered nurse and board vice chair of Whole Washington, but making comments today on personally, from my own personal point of view. And I just want to say thank you very much to all of the commission members who gave some public comments on our bills. I just want to say thank you for your support and thank you for all the work that you've been doing. And we really are eager to hopefully work closer with you in further refining some of those emergency bills and creating something that will help us get through this moment and get us further down the path. Thank you again. You guys have a great day.
Thank you. And I'm not seeing any more hands, but we'll give that just a moment. Okay, I think that wraps up our public comment. Vicki, did you want to go back to voting on the minutes, or Ross, did you
Yeah.
want to speak about distributing public comment?
Maybe let's do the minutes, then I'll raise the public comment question.
Okay.
Thank you.
All right.
Thank
So
So we looked at the minutes from December. At that point, there were no comments. We've been joined by Jane and Joan. Is it not Nikki yet? Okay. So just checking to see if there were any changes or updates needed to the meeting notes from December. And if not, I would love to entertain a motion for approval.
I second, Vicky. Thank you. This is
Oh
Mohammed.
no, I wasn't making a motion.
Oh, okay. I make a motion to pass it as it is. Then.
Thank you.
Mohammed, I got you. I second you.
Thank you,
Thank
Joan.
you.
Sorry. Is there any other discussion? All right, all those in favor of approving the December meeting notes, please say aye. Aye.
Aye.
Any opposed, say nay. All right, motion approved. Thank you, and thanks for getting here however you had to. Ross,
Thank
back
you.
to you.
Yes, thank you, Chair Lowe. The staff of the Universal Commission wanted to bring a question to the commission on the public comment topic. We are currently working with FTAC and a sub-work group on a number of different design elements. And a question that we've been getting from the public is they would like to participate in the work that FTAC and the work group is doing and submit materials kind of on a rolling basis in between meetings to the work group members or FTAC for their consideration. Our current process has been to just include public comments and meeting materials in advance of the meeting, how we did today, as opposed to sending them as we receive them to members. Some of the concerns with doing that would be that it would be duplicating the comments, as we are statutorily required to keep those comments in the meeting packet, but also just not wanting to confuse members. Alternatively, this is really good information we're getting from the public and want to let the commission know about that and make an informed decision about whether they'd like to receive those materials in between meetings. So just to wrap that up into a question for the commission to consider, would you like to proceed with our current process of receiving public comments in the meeting materials a week in advance of the meeting? Or would you prefer a method where, as public comments are received, they come to you on a rolling basis, meaning as we receive them, we would circulate them out to the respective body, whether that be FTAC or the commission, depending on where the comment is directed. So happy to answer any questions or provide any clarifications, but just wanted to bring that question to the commission as we've received this a number of times from the public.
So if I could just jump in 1 second, one detail, I don't know if people are aware of the timing that we go by. For a comment to make it into the meeting packet, the deadline that we work with is 2 weeks before the meeting. So that's why on this slide, you see the date, received November to January 29th was 2 weeks ago. So anything that comes in that 2 week window leading up to the meeting, a written comment, anything we received in that window goes into your, what are we in February? Goes into your April packet. Just to give you an idea of the timing.
Thank you, Mary. And again, happy to answer any questions or provide any clarification, or if the commission doesn't have a opinion today, this issue that we could bring back after an opportunity for further thought or consideration.
Does anybody have any thoughts? I always have thoughts, so I like having them all together, but I also like getting them, when it's pertinent to the conversation. So I know that staffing is an issue.
That's a great
sending them out. What is the impact to you guys?
The concern for staff would be that I wouldn't want to put staff in a position where they would have to pick and choose which comments deserve to be sent on to commission members or FTAC. Just, not wanting to have staff have to, make that decision. So that would be the concern. It would be doable to send these comments on to commission members or FTAC members. We just worry that it would get lost in the shuffle or, just unclear why you're receiving it without perhaps proper context. But as I noted, it could be helpful to the groups that are doing this work, particularly the FTAC work groups. So not an easy answer. That's why we brought it here.
Mm-hmm. I do agree that I think emails would get lost in all of our emails, but also it's helpful to have the comments that are connected to the work we're doing. Is anybody on any other boards or commissions that have wrestled with this too, that have thoughts about how to handle it?
Yeah, I can speak to our Healthcare Cost Transparency Board and those advisory committees. We follow the similar process that the Universal Commission does, which is following a schedule similar to what Mary mentioned, where we ask for comments a week in advance of the meeting, then bundle all of those comments together into the meeting materials, which are then sent to commission members, cost board members, and the public. So traditionally, we do the bundle approach. I think with the commission's work, there is kind of that ongoing work that the work groups do. So that it's slightly different, which I think is why that question has come up in this context and perhaps not in some other board or commission contexts. I see a lot of quizzical looks, so I am happy to maybe table this and see if there are any questions or pieces of additional information that we could provide that might make this decision easier. And unless there's any concern from the commission, we'll just continue with the status quo and then seek further input at a later time. Oh, my apologize. Dr. Kwangat, please go ahead.
Yeah, thank you for thinking about this so thoughtfully. I do like the bundled approach, but also see the advantage of having work groups having earlier access. Is there a possibility to maybe make the comments accessible in a folder that a work group could look to in advance of their meeting if they wanted to do that before one of our scheduled full commission meetings?
That is a wonderful idea. I wish I had thought of that. That is a great idea. And that is maybe something we can just make sure is compliant with the OPMA, but could certainly investigate that idea and see if that's a workable solution for this problem.
And since Pam is here on behalf of the Financial Technical Advisory Committee, FTAC, Pam, do you have any thoughts, or have you heard anything from the committee members?
I don't think we provided staff any more assistance than you. Well, actually, you did just come up with a great idea. We did not. We had the same concern, like what is the impact on staff, and the kind of pivoting between, receiving things in a timely way and also receiving them when it's pertinent. One of the things I think I've noticed the entire time I've been involved is that there's not always a good feedback between our committees and commission and the people who are coming forward with comments. So sometimes they just don't know if their comments have gone into the void or they've really been heard. And to me, that might be an important aspect to think about as well, because I think a little bit more, feedback at the time might be helpful for people. I know I think a lot about comments, but it may not be evident to the public members who take the time to talk to us that we're actually taking them into as much consideration as we are.
Yeah, and we have heard from the public that they want to know we're here for them, and we try to in the notes say back what we've heard comments on. But yeah, I agree. But I do like the folder idea, if that works.
I like that too.
Yeah. My experience with city council was we just got emails right up until our meeting, and that was sometimes not really helpful. So I don't recommend that.
That is excellent. So unless the commission has any concerns, we'll plan to implement a shared mail or online folder system for commission members and FTAC, and just make sure that there's no OPMA concerns, and then could give a status update at the next meeting, just to let you know how we've progressed. As long as there's no concerns.
SharePoint though, because I feel like that would be a problem. You know that like DOH has Basecamp. Does Healthcare Authority have something similar?
I think we have Dropbox, which might be a platform we could use and then share with individuals who are on FTAC and work groups in the commission, but could certainly do some more research on that as well.
Okay.
Thank you so much for your time on letting us bring that question to you. And thank you, Dr. Tauquangat, for that excellent idea. So thank you all. And I believe now I'm handing it back to Vicky for commission member report outs.
Okay, I think I'm missing that. Oh, here we go. So, are we in the right part, Mary? Oh.
Yep, it's commission member
Just
report.
going
We have a
through
lot
all
of
the. These are
lot of
all
written
the
comment in this packet.
Yeah, comments we received. Okay. All right, and public comment can be provided at any time, as we discussed. There's a one email address that you send it to, and it will get to us. And now we'll have our state agency report outs from commission members. I welcome members to share any updates that might align with the commission's work. And we'll start with our agency representatives. And Joan, you're first. Must be alphabetical by last name.
I'll take it, just narrowly edging out Jane. So my name is Joan Altman. I use she, her pronouns. I'm the Director of Coverage Strategies and Expansion at the Exchange, and also represent the Exchange on this commission. And thank you also for everyone for submitting the public comments and for making time to speak at these meetings. It's always one of the more informative parts of these meetings. I will give a few high-level Exchange updates that might be relevant for the work here. First, we just finished open enrollment for 2026. Everybody is sort of eagerly waiting and watching to see what the impact of some of these more recent federal changes will be, and particularly the loss of enhanced federal premium subsidies. So we've been monitoring that. I will put into chat, or Marion team and Vicki, get to you a press release that we put out at the end of last week that speaks to the numbers, if they're of interest. We have just under 300,000 people who are in a qualified health plan. We do have a higher number of people canceling coverage than we have in the past, and we expect over these next couple of months, as first month's premiums are due, that we'll continue to see some attrition as it relates to coverage. We're pleased we put some mitigations in place to sort of help prevent as much dropping as was initially projected, but a lot of work there to continue to try to help people with access and affordability issues in the face of some of these challenging federal changes. I'll note particularly in the immigrant health coverage space that there have been some federal changes, both removing federal subsidies and sort of changing how people with various immigration statuses can access care, that have resulted in some population-specific impacts. An example is, our DACA customers, the Production Child Arrival customers who lost access to federal subsidies. About half of those customers have dropped coverage. We also had some low-income, lawfully present customers who can't get onto Medicaid because of their status, who were previously allowed to come onto the exchange and get subsidized coverage. Those folks lost federal subsidies, and about 30% of those people have dropped coverage. So we'll continue to watch these population-specific impacts and continue to look ahead to see what as a state we can do to help maintain coverage pathways. I'll note that there's a bill moving through this legislative session, Senate Bill 6210. The exchange is working with the governor's office and OIC and our legislative sponsors on, that would provide a few more tools for the exchange board, who's a bipartisan board, to address some of these access and affordability issues. So we're hopeful that can continue to move forward. We're also working in community with a lot of you and a lot of stakeholder partners on trying to find sustained revenue for our Cascade Care Savings, our state subsidy program that's trying to catch people who are losing federal subsidies to keep the coverage affordable for them. So from a legislative perspective, those are some areas of focus, and also watching with interest and support some of the data privacy bills and affordability and cost containment bills that continue to move through, in addition to the bills that have already been mentioned here, looking at how to further kind of more universal access. So I think that's it for me, unless people have questions for the exchange.
And the health plan certification bill, that is kind of to really simplify choices, or?
Oh, yeah.
For the number.
Last year we ran a bill to try to simplify plan choices that would have just limited the plans in the exchange to what we call standard plans or cascade care plans. This bill takes the approach of, in several other state-based marketplaces, the exchanges have a little bit more authority around the plan certification criteria to help sort of curate the market shelf and or address bare counties, and or sort of help promote affordability. So it adds, what the bill essentially does, and happy to share it with folks if it's of interest, is it adds some authority for our board, sort of in partnership and following a stakeholder process, to look at plans as they're filed, address whether they're bare counties, and then if there's sort of to take affordability factors into account when thinking about plan certification. So a little bit of a lever, sort of more consistent with our state colleagues, to provide a little bit more curation of the market.
Thank you. Any other questions for Joan? All right, Jane.
Hello, everybody. Great to be here. OIC's work at its session. So lots of session related things. As Joan indicated, we've been working really closely with the Health Benefit Exchange on their legislation. It's Senate Bill 6210. It actually passed the Senate yesterday, so that was a big step. And now it's going over to the House. Another big priority bill that passed the House yesterday was House Bill 2242, which is a bill that's aimed at preserving access to preventive services. So immunization, cancer screening, well, child care. And that bill passed the House yesterday. So we are really hopeful that it will get through so that the Department of Health we will not be bound to the decisions that are being made in the other Washington by the Advisory Committee on Immunization Practice. So we're really looking forward to that bill getting passed this session. We are actively supporting Senator Robinson's bill to regulate the corporate practice of medicine so that private equity can't tell a doctor how to practice medicine. We are also actively supporting legislation, I think it's House Bill 2458, that Rep. Taylor has introduced that would increase the opportunity for the Office of the Attorney General to review sort of merger and acquisition activities, not just between healthcare providers, but also between healthcare providers or hospitals and non-healthcare entities like private equity. And there are lots of revenue bills. So relevant to the public comments about how tough it is to finance the system, there are about 4 different bills that are sort of under consideration right now to try to fund different aspects of the healthcare system. And they are getting a lot of attention, and they are very controversial, but they are looking to fund things like our behavioral health crisis system and to ensure that there's access to abortion services for people who are underinsured or uninsured for abortion services. There's a proposal to do a premium tax increase, and that doesn't say exactly what the funds would be used for. There's a proposal to capture some of the surplus that nonprofit insurance companies have to fund, as Joan was indicating, Cascade Care subsidies for calendar year 27. The Office of the Insurance Commissioner is sort of remaining neutral on all these bills, but because this is within our wheelhouse, we're providing a lot of technical assistance. Outside of the legislature, a good thing is that a new law regulating pharmacy benefit managers went into effect on January 1. So it's got some core protections for consumers to try to preserve consumers' ability to get prescriptions at independent pharmacies rather than having to get them through the pharmacy that's owned by the pharmacy benefit manager or their health plan, and also prohibits some pretty common business practices that PBMs engage in that we think are not helpful to consumers. So that's newly implemented. And then probably the big development this week is that every year, the federal government, the Centers for Medicare and Medicaid Service, puts out a rule that says, here are the rules of the road for individual health plans for the upcoming year, in this case, for plan year 2027. And there are this is a proposed rule. Comments are due on March 13th. There are some pretty controversial things in that proposal that would make it even harder for people to enroll in coverage through the exchanges. That would require the state to pay for extra benefits. In Washington state, for example, that would be things like hearing aids, rather than having those be paid through health insurance. There are a lot of provisions in there that are encouraging what are called catastrophic health plans, which are health plans that have deductibles in the neighborhood of like $12,000 a year. So there will be a lot of attention paid to the comments to that notice of proposed rulemaking. And then the other big activity that's going on is the federal government has issued 2 proposed rules that are aimed at eliminating gender affirming care for minors. One that essentially says that a hospital would not be able to get Medicare or Medicaid funds if they provide these services to youth. And another that says that federal Medicaid funds cannot be used for gender transition services for youth. And the state agencies and the Office of the Insurance Commissioner and the Attorney General's office are all working together to submit comments on those federal rules. So no shortage of activity to respond to from the other Washington. That's what we've been doing.
Okay, thank you, Jane. Any questions or comments? All right, Dr. Quanget.
Thanks, Chair Lowe. And yes, as Jane mentioned, DOH is also very busy with ledge session. And, she mentioned 2242, which is such an important step to ensure accessibility to evidence-based preventive services like vaccines and other preventive services as well. One thing that's keeping our teams very busy right now is a measles outbreak. Actually, we have multiple measles outbreaks that are resulting from multiple introductions of measles from people who are infected from South Carolina into Washington state. And as with many outbreaks, the measles outbreak is most prevalent amongst immigrant populations where there is suspicion of government and suspicion of low trust in vaccines, and I think for me, it reminds me not only of the importance of vaccination, but also that healthcare access is more than just coverage. Healthcare access also means ensuring that healthcare services are culturally appropriate and linguistically appropriate. Right now we're up to 23 cases. I will put the link to the Measles Cases website in the chat so that people can get updated statistics every Monday, Wednesday, Friday. The Department of Health updates those. And so far, we are not seeing evidence of ongoing community transmission. Right now, transmission has been occurring within family networks. And so that's encouraging, but we have to be very vigilant about the possibility of community transmission. So I'll stop there and happy to answer any questions.
Mohammed, did you have a question?
Yes, thank you. Not a question, kind of a comment. Thank you for sharing that. I know I'm from a community where we've as an organization, Somali Health Board, previously that I worked for, we combated misinformation on vaccines and all of that, and all the parents that are concerned about the MMR vaccine because they thought it was related to autism with young boys and all of that. I last time there was an outbreak, especially in Eastern Washington, we kind of dodged a bullet. I think there was no cases in at least King County, in my knowledge, and these things are made difficult by lapse in coverage and things people are not getting, losing health insurance and all of that, and it just points to now more than ever the urgency that we need to move with the universal health care coverage. Just wanted to add that comment. Thank you for sharing. I'm gonna look at the website and share it with my community partners as well so that we can stay on top of this.
Yeah, thank you so much. And it's also a good reminder that we always need to be continually engaging communities on these issues, and that we need to do outreach to immigrant communities, again, in a way that's culturally and linguistically appropriate. And we need to do that when there's not an outbreak, so that we can prevent these outbreaks from occurring. So thank you for that comment, and thank you for your work with your community.
Thank you, Dr. Quanget. And Dave's not here. I'll try not to do a joke. And Omar, did you have an update from the Office of Equity?
No updates, similar to everyone else, just tracking bills, and then just highlighting, I think, as Ross just kind of brought up, our immigrant communities too, and so tracking a lot of bills associated with protections for communities, a couple of bills around data protections specifically, just to throw a number out there, House Bill 2637, just monitoring some of these bills. And then language access as a big concern. Also 2475 is a bill that we're also tracking and providing more education on as it goes through the process. So just a lot of bill tracking for us.
Thank you. Badisha, did you have anything to share?
No.
Okay. And Mohammed, anything else from you?
No, not really commission business related, but this might be of interest to Mary. So I was formerly employed by Somali Health Board. I'm no longer employed there, but I'm still a very active community advocate, especially in policy. And just wanted to update my email information and all that so that I can continue getting up to date with the commission and we can attend the meetings. I'm joining today's meeting from East Africa, by the way. I didn't give enough notice. That's why it's late, but I wanted to attend this one because I know how important our work is. So
Wow.
no other comments. Thank you.
Thank you for being here. You might get an award from the furthest away commission member.
I think it's a 10-hour time difference. If
Oh
I'm
my goodness,
not what
Mohammed, thank you
we
for
looked
being
it up
here.
this morning. So thank you. We appreciate it.
And
Thank
for the American Indian Health Commission of the Tribes, we also have a data bill, and it has something about a notification or to tribes of notifiable conditions. And I think we're really worried about the measles outbreak too, and that making sure that like when things like that happen, if it happens on tribal land, that we're getting the same notifications that a local health jurisdiction would get, and in a timely fashion. So yeah. And just, I know our tribal leaders have been back in DC this week working with Indian Health Services on budget formulations, and there's a lot of concerns about what's going on at the federal level. But I'll hear more about that when they get back next week. But thank you, everybody, for your updates. And if it's okay, we can move on to the next topic, which is work plan updates. And Mary, tab 4 in our workbooks.
Yep. Thank you, Vicki. The work plan update is short and sweet this time around. Audrey, if we could go to the next slide. We're going to talk about the update, where we are, and which items are on today's agenda. And also, we launched a new webpage that is the What We're Working On webpage. I'll show you how to find that and what's on there. So the next slide. This shows you where we are with our key design elements, the green ones. The work has been done, or the proposals have been filed away. The orange means we're working on it. And I realize in the far right that ledge report should be green for the future ledge reports, because we are working on that, or should be orange rather, because we are working on that. But if we go to the next slide, here are the pieces, the universal design elements that we are working on. The provider participation and reimbursement and financing belongs to FTAC, and provider reimbursement is on today's agenda. Pam will be talking about that when she gives her FTAC update. And then enrollment, infrastructure, and governance are the assignment for the Universal Healthcare Commission. So we're going to talk about that later in the meeting as well, clarifying the definitions, and try to get our enrollment work group together and launched. And it'll be nice when session ends to be able to jump into that work a bit. So the last slide I have, the last one, is a new web page. We are often asked, you wrap up these proposals and they get put into the annual report, but what if I want to go look at them? So we took the information we had and created a new page, and it's the What We're Working On web page. And it just gives you, this is a screen grab from the middle of the page, completed, in progress, future elements. The line at the top sort of gives you the breadcrumbs of how you can find this page. If you go to the Universal Healthcare Commission page, you can go to What We're Working On. And at the bottom, that's kind of a long, messy URL. But if you type in all those letters, you will land on this page as well. You can access this from the general Universal Healthcare Commission page. And if let us know if this meets the request and what folks were hoping for, to be able to keep up on where we are with various things. And that is the end of my update. I don't know if anyone has questions about things. Okay, Vicki, I think
Yeah.
it's time for Pam.
Yeah, thank you. As mentioned earlier, Pam is back as our liaison to the Financial Technical Advisory Committee, and she's here to give us an update from their meeting, which was last month, January. So it's tab 5 in your workbook if you're following that way. Pam, thank you.
Yeah,
We
thank
really
you, Vicki.
appreciate you coming back. I don't think you know how
It's
much.
like I was never away. Okay, so let's go to the first slide, and so this is kind of an overview of what we worked on at our last meeting. As always, we start with public comment, and we are deeply immersed in the question of provider reimbursement. And also I have begun work on the OIC proviso. I'm not going to talk about the OIC proviso because that's going to be coming up later in your meeting. Next slide, please. Public comment focused on the recommendations about how to use the OIC proviso funding, and how particularly people zeroing in on the question of financing, not surprising. And then a recommendation to emphasize cost savings when designing a universal system, which is how are we going to, we can't afford this system. How do we move to a new system that's more affordable and bring down prices at the same time? Next slide, please. So in terms of provider reimbursement, we have been working in a smaller work group, but with a lot of communication between the small work group and all the FTAC members. So for right now, what we're going to talk about today is the draft guiding principles, which it's on our agenda, and I'm going to be taking you through some of that. And the draft principles, which will kind of provide kind of the framework for how we think about provider reimbursement, will be ultimately the appendix to the design proposal that comes to the Universal Healthcare Commission for feedback and approval. The draft design proposal is, as I said, currently under development. Drafts are going to be circulated back and forth between the full FTAC membership and the work group, and we are expecting to bring that back to the April commission meeting for more feedback and discussion. Next slide, please. The current reimbursement proposal focuses on transitional solutions. This is as a result of your guidance, which is quoted here. And I wanted to note that this is a this is a tricky element that we experience, kind of grappling with within FTAC, which is we're trying to get to an idealist design from the system that we have, and the path from here to there can be challenging to figure out. And so a number of what we're thinking about in terms of this report to you will be really looking at transitional steps. And so that's one of the things we wanted to ask about today. And this is just to start you thinking is, does this align with how you're thinking is that the report will be kind of focus on a transition from our current system to the new system, rather than it just pops up as kind of idealist, kind of an idealistic, perfect healthcare system. It's really thinking in terms more here to there. How do we take what we have now and move it to something that's completely new and works differently and works in a much more equitable way in terms of how providers are reimbursed? And is this what the commission is expecting to hear from us? And do you have any questions about that? I'm posing that to you now, understanding that that might be coming at you from the blue. But if anybody has any feedback now, please, speak up, or we can kind of talk about it as I walk through the rest of my report.
Pam, if I could just jump in for just one quick thing.
Yeah.
The quote you see in the middle of that slide where it says these initial recommendations fall within, that's lifted from the draft proposal. In case you're wondering where that quote came from, everything is in draft form and very drafty right now, but that's where that idea came from. And the reason we put it on the slide, we felt that sort of encapsulated what the approach is right now, and just to see test that to see if that's what commission wants to see.
Right. And thank you. Thank you very much, Mary. And I said kind of per your guidance, but I didn't really attribute their quote back to the report. So I think that's really helpful. Any other comments besides Mary's? And I'm hoping that looks familiar.
Pam, why don't you go ahead, and then I have some questions / thoughts, but first I want to hear what you have to say.
Good. I wouldn't have it any other way, James. Okay. Okay, then my second question to you is, would a standalone roadmap which would describe gradual implementation and provider reimbursement mechanisms serve the commission's goal? So basically, we're looking at a roadmap that would kind of describe a way of getting from here to there. It's not going to be a roadmap in the sense that you must follow this way, there's no other way to go, but it actually would be a way for us to understand how to get from here to there and provide a thinking tool to the commission. And is that something that would be helpful? And that's something that we're offering to provide.
So I definitely think it would be helpful, Pam, I think. But do you have more that you wanted to present on?
I think I do. And I think that it might be helpful to kind of flesh out what these things mean. So let's go forward.
Yep.
Okay. So we developed a set of principles. I believe there are 10 of them. And we provided those to you as in advance. So they're part of the slide deck here. So some of you may have looked at them. Some of you may not have had a chance to look at them yet. We've discussed these extensively among the group. And by and large, there's unanimous agreement about them. I would say I'd almost prefer to use the term consensus rather than unanimous agreement, because there's generally how we make decisions is to try to come to consensus first by kind of the give and take and understanding each other's points of view within our group. Recent discussions and comments have focused on making sure we have an appropriate level of specificity, acknowledging that an adopted framework that is too prescriptive could cause more problems. So if you think about provider reimbursement, we all know situations, all of us have a lot of experience with the healthcare system in which a wrong decision has resulted in maybe a provider not wanting to offer services anymore because the reimbursement doesn't work, or people not being able to get care that's absolutely necessary because providers are not willing to care for them at that level. So the incentives can be surprising, that can create outcomes that were not intended. And so I think that's why we're being really careful at how we look at this language. Another principle, another thing we're looking at is equitable reimbursement for all enrollees, so that they're not incentives to treat people differently within the system. A sustainability of transitional approach and universal design. So do we have a sustainable system that we can afford and keep going forward? And then appropriate incentives for providing quality care. And that has been an area where there's been a lot of discussion as well. And then what we're hoping for is commission feedback to FTAC. I believe on the next slide, I think we have the actual principles, the list of principles. There are a lot of them. We're nothing if not thorough. I want to draw your attention to the first one, which is a way to help us think about some of these issues, which create uniform and consistent reimbursement systems across all providers and payers. And the term consistent was the most discussed word of everything within these 10 principles, because in our current system, people can be treated differently depending upon what the provider reimbursement is. So there was a desire by some members to use the term identical rather than consistent. The alternative to that is that as we're developing a system and trying to transition, language can be our friend or it can be a problem, because if it's too prescriptive, it can shut off kind of the ability to move in a gradual, thoughtful way from one system to another, from one reform to another reform. So that was one there was a lot of energy about. I'll just read the captions to the others, which is improve affordability of the healthcare system, maintain and improve access to needed care, maintain and improve fairness and equity of the reimbursement system. And go on to the next slide. Rebalance payments to support traditionally underfunded care, which I think is something that we've all talked about extensively. Number 6, reduce waste and improve the quality of care provided. I'm zeroing in on this one because there was the other one in which there was the most discussion. And this came from public comment from some people who are watching carefully what we do. And it came as a surprise to me, because reduce waste and improve quality of care to me sounds like mom and apple pie. But if you think about current incentives in our system where there's a lot of administrative burden on providers. There's a lot of demand for productivity. There's acquisitions of provider groups. So that reduce waste and improve quality can be viewed differently depending on which lens you're looking through. And so this is one probably we're going to have to do more thinking about and more discussion. So that one's one of those. That's also a good example of public comment having an impact. Number 7 is standardized key aspects of payment administration. 8, assure reimbursement system transparency and accountability. And there's more. Assure reimbursement system stability and predictability. Ensure that payment policy aligns with capacity policy. I want to acknowledge that Bob Murray helped draft these, the initial version that we had, and then we had a lot of discussion within the smaller group and within the larger group about these. 10 is a lot. It's a lot to take in a meeting. I think that they're really thoughtful. I think one of the things that is just really important to think about is because of you can do a lot of good and a lot of damage in terms of how you think about paying providers in a provider reimbursement system. Having principles that provide guardrails is important, and then thinking gradually. So kind of going back to the first questions about transitional steps and thinking of a roadmap. And then now having looked at the principles and just reading a little bit from me, do you have additional questions and thoughts? And Jane, I know you're sitting on some questions.
I am. This is great. So can we go back a slide? I'm trying to think about the challenge of taking everything on at once versus building the system by taking on particular things first, particular types of care first. So, and pegging on to item 5, right? When you think about the Healthcare Cost Transparency Board and what they've said, when you think about the reference-based pricing bill that just passed that said you want to bump up reimbursement for behavioral health and primary care, it seems that because primary access to primary care and access to outpatient behavioral health services seem to be the issues where there's the most pain in terms of right access to care and payment levels, et cetera, but yet are also probably the most like popular when you talk to consumers about, you know, what do you want first and what are your biggest challenges right now? Everybody can walk into a hospital ED, but everybody can't get an appointment with a primary care provider or a mental health provider. And so, and then does it make sense to think about sort of, we're going to look at how you could apply these draft guiding principles if we were to start with primary care and outpatient behavioral health services, where we already have, and preventive, I think of preventive services as rolled into primary care. So we have, it's a relatively fixed set of services. We have models that we know of for primary care that deliver good primary care. We have the collaborative care model, right? We have direct primary care models. Is there enough there that we could sort of, and then standardizing administration, is there enough there that we could take an approach of universalizing chunks of the system and then sort of working on standardizing the rest of the system so that it sort of wraps around those core universal services? I'm just trying to think of some approach that doesn't mean, and you know, we've been thinking about transitional approaches. So that's kind of what I've been cogitating on.
Yeah, I think that's really interesting. I mean, there's how you organize a practice of medicine versus how do you look at a system, which are different things. And so if you take just primary care, you can probably do a lot. If I'm understanding what you said, you could go a long way in kind of looking at payments. But the fact that primary care providers are some of the lowest paid providers, within our health system, you're not really addressing that issue. So what I think I think it's a really important discussion topic for how do you break this down? Do you try to do something that takes on the whole system, or do you try to do it in pieces as you've suggested? I think
Yeah.
it's a really interesting idea.
Well, and I think, right, we know behavioral health providers and primary care providers are poorly paid in our system.
Mhm.
And so if what you're starting with is this is a commitment, we have to make primary care appealing, we have to make behavioral health appealing, and part of it is having it be something that you can sustain a practice on when you've just come out of medical school with $200,000 in debt, like my daughter-in-law. So if you start with that assumption of we want to look at how we pay for primary care and behavioral health and pay more for it than we do now, it drives the rest of the discussion about, all right, if we don't want things, if we're not just adding costs to the system, then it really does drive the discussions about how do you make the system more efficient? Should we pay as much as we're paying for the non-primary care services, et cetera, et cetera. So I think it helps to propel the discussion in the direction that we want it to go. But
That's
I'm going to
great.
stop talking so Dr. Kwanget can talk.
Yeah, I like that. Dr. Kwanget.
Well, thank you for presenting these very thoughtful draft guiding principles. And I agree with everything Jane just said. And I was really happy to see preventive care specifically called out, because I think all of us understand healthcare to include preventive care. But I think for many people, when they think of healthcare, they think of just, acute problem-based care. And I think it's really valuable for us to be calling out prevention as really an important part of care. I guess another consideration, and I'm not sure if this is the right venue for this, but is there an opportunity to facilitate more clinical community linkages? And I'm thinking of, community healthcare workers, for example, doulas, et cetera. As particularly as we face a shortage of healthcare workers in rural communities, there may be opportunities to use community health workers, and if it's possible to reimburse clinics or organizations for the work that they do, then it's more likely that this really important evidence-based activity could be used. I think also thinking in terms of how do we serve and increase access for immigrant groups, and non-English speakers. The use of care navigators and community health workers can really do a lot to improve access. And so I'm just wondering, is this a venue to maybe open that up for greater consideration? I know increased community clinical linkages was once was part of the state innovation model, was one of the principles of the state innovation model 10 years ago, and I think it's still relevant today. Thanks.
Yeah, thank you. I think that fits really nicely under, supporting traditionally underfunded care, because underfunded care can take many forms. It can be community care, and as you've described, it's translation services. Other questions or comments?
And then just for kind of riffing off Dr. Kwanget, the Indian healthcare delivery system, which is universal healthcare, even though it's been chronically underfunded, the clinics are funded, and then the primary care provider manages the care, which is basically how things used to be, is how I remember healthcare when I was a kid. So I know that like we have the federally qualified health centers, and most of them get like the HRSA 330 funding, which is some base funding and then an encounter rate. And those really help out in rural areas, but the smaller provider shops don't, they're subject to whatever they can negotiate with insurance carriers. And I like the idea of looking at a system that, because there's a base amount of money you need to run a clinic, right? Depending on how many providers you have. And then on top of that, when you see patients, then you get other funding based on the care you provide. So that's like a really untraditional way of funding, I guess. But that's where you can get funding to do like doulas and community health workers. We call them community health representatives. That's part of the base funding. And then when you do the medical care, you can get reimbursed for that. But it's just like a completely different way. It's so different from how we do things that I don't know how we'll get there. And I think that's my problem. You talk about a roadmap. We had like this direction from the work group to get from where we are to single payer through kind of changing the system and rotating it to this different way. Is that still possible? I don't know. It's kind of scary out here now, but it'll involve us really thinking differently and not being really stuck in how the system works now. We have to move away from some of that stuff, and I think that's hard.
Right.
So I don't know where that fits in the principles of just really being able to think outside of the box and not trying to correct what we have, but really moving to something else.
Yeah, but it's also, the idea of moving to something, and when I said gradual, I don't mean too slowly, but I mean doing
Yeah.
things more of a stepwise way, because you can't flip a switch, or it can be dangerous to flip a switch in healthcare
I
because you
completely
can get
agree.
very unintended
Yes.
consequences.
Mhm. And I know because we're the people that suffer the most from unintended consequences, the most vulnerable.
Joan. I saw Joan's hand. I don't know where she went.
Joan,
I think you're still on mute, Joan.
Oh, can you guys hear me okay?
Yeah.
That's great. The snarky comment I made to Pam will get excluded from the public record, and we'll all be better for it. Welcome back, Pam. I had a question and then a comment. I'll start with the comment in terms of, does an incremental roadmap help us? From my perspective, it would help the commission. I think sometimes it can be hard to get forward traction without the from here to there, because sometimes when we want to be here, particularly with our legislative members, I think it's helpful to show that it's possible and to have ways to do it that move us forward. So I like the idea of sort of road mapping it out for us. In terms of the guiding principles, can you speak more to number 10?
Yes.
I was hoping to just figure out a little bit, get the 30-second context on if this is where the reimbursement policy and affordability of health coverage are meeting, and wanting to make sure I'm understanding that.
Ensure that payment policy aligns with capacity policy. The reimbursement system should integrate and coordinate payment and healthcare capacity and staffing policies to ensure adequate access to affordable care. So I think that what we're wanting to do is not endanger capacity, so that your payment policy doesn't impact your capacity to deliver services. And I know that I know Bob Murray is is observing today. He was sort of the original drafter of this. I would invite him to say something, but I don't know that I don't think I can do that. I think he has to be brought on as a panelist. But maybe that can happen while we go on to Mohammed's question and come back. And then, because I think I would really prefer him answer your question, because I think you'll get a much more satisfying answer from him. So, Mary, can that work? I'm gonna call on Dr. Mohammed while.
Yep. And then we can go to Bob.
Yeah. Okay, Mohammed.
Thank you, Pam. No question. I might also wait for that response to actually articulate this question. But overall, some of the things that I personally and from organization as a community observed is, for example, to make it truly accessible to everybody. Adding those supplemental services such as language service, which is like very key, is important. But because of the services that have been provided towards language services thus far, we've learned a wealth of information. For example, what makes the community embrace translation services, especially in medical settings. How that can bridge the cultural misunderstanding and mistrust between the system and the communities. So I would be more than happy to engage in that conversation at some level if need be. But that is one of the key services, and I would love to wait and hear the response to John's question as well.
That's great to just think about the breadth of services. I saw Bob, my lifeline. So Bob, if Bob's able to answer the question Joan brought up on principle number 10.
And Bob, it looks like you have been promoted to a panelist, and you should be able to just unmute yourself and go ahead. And if you're speaking now,
He's been muted. He doesn't have a red thing with a line through it.
Yes, it looks like you should be able to. Let's see.
He's on, but we're not hearing him. I'm going to ask a question of the group while we hope that Bob joins us, which is if we went back to the original question, looking at the gradual, kind of working from a transitional way. I don't want to say gradual, but transitional. And was that that direction that was in the report and had come from the commission, kind of starting with Vicky, are we still consistent there? Because I think when you see the report from FTAC, it'll take that approach, and we want to make sure that we are on the right track.
That here's where we are, and we have to move this way, and what's yeah, definitely.
Okay, that's great. And Dr. Kwan-Yat.
Please call me Tao.
Okay, Tao.
Yes, yeah, I agree. I think having that incremental roadmap would be really helpful. This is a new area to me, though, and I know that there might be times when sequencing implementation is important. And so I think maybe some awareness of when, say, a step won't work unless when step A won't work unless steps B and C are also simultaneously taken. That would really help as well. Thanks.
Great, thank you.
Can we go back to the first principle?
Yes.
We spent a lot of time on this, and so just go back 2 slides, I think. Audrey.
That is the most discussed principle.
Right. I guess this is where I was kind of focusing on, because it needs to be flexible to meet the needs of the community that's being served. And so I don't know, consistent yet flexible, like both Mohammed and I have talked about community health workers or community health reps. And I think those are appropriate for the communities that we work in, but maybe not other communities. And that might be a different kind of reimbursement rate.
Mhm. I think one way to help that really helps think about this one is thinking of rural healthcare. That a rural hospital is a really different operation, financially and in every way you can imagine than urban hospital. And so that's one of the reasons, the idea of flexibility is particularly in a transitional state, the flexibility is really important. Thinking really differently. The other is going from, in multiple insurers, multiple payers to fewer payers. Going from, population groups that we may be in a situation where some population groups could never come into a state system because the federal waivers are never available. So that the flexibility to deal with all those different situations is really important, but kind of hanging on to the principles about that people's care should be equitable, it should feel the same. Should be rewarded in the same way is that kind of the guiding principle there. I see Bob with a hand.
Yeah, Pam, can you hear me? Sorry, I had some technical difficulties.
Yeah. Thank you for your persistence. We're glad.
Yeah, sure, not a problem. So, could you repeat the question again?
Okay, so Joan Altman asked about question about principle number 10. And I think that you drafted principle number 10, and my preference would be that you explain it rather than me.
Could you call up 10? I don't recall exactly.
Yeah, and we just
had
need
to do
flip.
with capacity.
Yeah, there we go.
Yeah, I guess I did hear your preliminary thought on it, and I think that has some validity. What I had in mind is that sometimes there is a disconnect between a capacity policy, oftentimes implemented through a state's certificate of need and planning methodology, and affordability. Oftentimes, providers, even though there's this CON process, that process becomes politicized, and the plans, as you know, the healthcare industry is sort of characterized by massive overexpansion in terms of facilities and acquisitions and things of that nature. So the general idea is to align payment incentives and your goals with regard to affordability and cost with the capacity decisions that drive whether hospitals can expand and build new buildings. And so, it was meant to kind of get at the need to align those two policies. And I don't know exactly how it works in Washington State, but in Maryland, the rate setting agency that I ran was very much at odds with the planning agency. The planning agency would approve new projects very easily. And as a result, you would have new hospitals or new capacity that would come online, which would definitely impact the affordability of the care that's being provided in the state. So this principle is meant to say, no, we need to kind of align both approaches, not necessarily overemphasize one versus the other, but align them so that you could end up with that affordability goal and access being met in a balanced way. Sorry, that was a kind of a wordy explanation, but just this idea of aligning both capacity strategies with your affordability strategies, and not just having expansion be somewhat open-ended, as it tends to be in many states that are regulated by CON, if that makes sense. So I'm happy to answer questions.
That was great. Thank you.
That's super helpful. Thank you so much.
Sure.
Okay. All right, Vicki, I don't know if there are any other questions. I think we're close to winding up.
All right. Last call for questions, comments. And again.
So Pam, just in terms of next steps for FTAC, what's the work plan?
Okay, so we are working on the report, which I talked about that was at the beginning, and that's why kind of getting an idea. Is transitional? Does that still make sense? Roadmap? Would you want to see that? We'll be coming back with a report. The principles will be appended to the report, and we will have kind of a similar discussion that we had today, kind of driving into more of the detail. And I don't think it's going to be a one and done kind of conversation. This is really heavy, complicated stuff in a health system. So we will begin that discussion at your April meeting.
Thank you, Pam.
Yeah, thank you.
Thanks for all the work on that. And also, Bob, thanks for popping on and helping us.
My lifeline there.
So are we still taking a break, or are we just gonna keep going forward? We have a 10-minute break, but we're already past that time.
How about a 5-minute break?
5-minute break? Okay.
I second the motion.
Now that we have a 3-hour meeting instead of 2-hour meeting, it's a lot different. All right. See you in 5.
All right. Thank you.
All right, are we coming back? We need a few more minutes. No? I know. We've been having all day meetings and having chair yoga breaks. Okay, well, welcome back, everybody. And I think if we can go to tab 6 in the workbook, we have Jen Scott from the OIC to talk about the Office of the Insurance Commissioner proviso funding. Jen?
Thanks, Vicki. And I'm actually a health policy analyst with HCA, and I'm going to be doing
sorry.
I'm going to be doing some project management work for the project that comes out of the OIC proviso, and also helping with contracting. So happy to be here to kind of kick this work off with the commission today. As a reminder, the OIC proviso was signed as part of the governor's budget mid-year 2025. And today we'd like to get the commission's guidance on initial decisions for getting this work started. So this slide covers the background of what the OIC proviso is. So it's $250,000 of the insurance commissioner's regulatory account, and the state appropriation is provided solely for the commissioner to enter into an interagency agreement with HCA around economic, actuarial, or other modeling related to the design of a universal healthcare system. And the funds need to be spent by June 30th, 2027. Next slide, please. So we're, in terms of assumptions, the final deliverable will be guidance for making a recommendation versus the recommendation itself, and will be related to one of the outstanding design elements. And just kind of for context, where another assumption is that the money will be used to pay a contractor who can accomplish this work. An example of that is the 2025 Milliman analysis. So that's the type of analysis that the proviso might pay for. Next slide, please. So this slide shows, again, the outstanding design elements and the first question. So we have a couple of questions, and then we did have a discussion, as Pam mentioned, at FTAC a couple of weeks ago about how to use the proviso money. And FTAC identified some potential design elements and questions, but asked that the commission formally identify the design element that the modeling effort should be based on. So that's what we'd like to be able to arrive at today, would be a decision about which element the work should be addressing. So I'm just going to go kind of breeze through the next couple of slides just for context, and then we can come back here to question 1 and have the discussion. So the next slide. The next question is, what elements of a unified financing system require actuarial economic analysis to support a recommendation to the legislature? And the idea here was an idea about prioritization. So there could be many things that would be a good idea or interesting, but just thinking about what are the things that are absolutely necessary for the legislature to know. Next slide, please. And these are some initial thoughts from FTAC and others. So around hospital global budgets, exploring more aggressive cost containment mechanisms, inventory of the state's revenue sources, incentives for private employers to opt into a universal system, and applying different reimbursement frameworks to the Milliman actuarial analysis. Next slide, please. A few more. Actuarial sensitivity testing of reimbursement scenarios for rural critical access and safety net providers to identify participation and sustainability thresholds. Modeling the costs of different administrative structures and looking at experiences from other states, and then modeling the cost of state-administered managed fee-for-service Medicaid. So if we could go back to the first question again. Great. So just wanted to kick off a discussion about what makes most sense to the commission as an element of focus, keeping in mind, again, that the proviso is to be used for an economic, actuarial, or other modeling effort. And would love to get some initial thoughts, and also invite my my colleagues and Jane to jump into with any other thoughts about this before we get started.
You covered it well, Jen. I don't have much to add.
Okay. So I know it's a big question, but just wondering, what do folks think about this?
Jen, can we flip through the next couple of slides again?
Yeah.
So the one thing that I keep thinking about is Pam, right? FTAC's going to be doing your roadmap work and bringing it back to the commission, right? So I'm trying to think about how this analysis, this funding, which can't do 17,000 different things, right? Because there's just not enough money to do that. I'm trying to think of what use of this funding would support the work that the FTAC is going to be doing on like reimbursement and payment. And like looking, hospital global budgets is one payment model, but then there's a whole bunch of other payment models. So I'm just trying to figure out how to make it fit. Am I making any sense, Pam? Or she might be gone. She might.
No, I'm still here. Yeah, you're making sense. I'm thinking of the work plan, although the work plan bubbles that we look at every month with Mary Franzen. And in addition to this, I know that we have to figure out the financing is also what's next up. So I think between those two things, looking at, I find the thinking about the financing of the system really intimidating. So that's an area that it could be helpful. But I also like what you're saying about the provider payment systems are also incredibly complex, and there might be different ways of looking at that.
Yeah, I mean, I don't want to go back and redo what's been done or retweak what's already been done. That I don't think that's productive. But I would love other thoughts on just ways to support FTAC most effectively with $250,000.
Jane, can you remind me what we already have, or Mary, on the shelf regarding financing, like the sort of cost to stand up and cost to administer?
Mary, do you want to talk about the work that's already been done in terms of the Milliman work?
Yeah, I can describe the Milliman work that was done just about a year ago. I think it was completed last March. That was an analysis of looking at the likely eligible population, the initially eligible population, and what would it take if we have this group of people, you know, the estimated cost of providing a Medicaid-like product, a PEBSEB-like product, or what was the third one? UMP, and the other one was Cascade. One of the Cascade.
Yeah, it was just silver.
Okay, Cascade Silver. And then Milliman developed cost of care analyses, and that helped inform the benefits and services recommendation that was made. I don't know if the decision initiated with FTAC or with the commission. My memory's failing me there. But looking at the numbers, that is sort of what informed the decision for the benefits and services initial proposal to say, this should be, let's start with UMP. That's actually where it makes sense. So part of what we envision for this actuarial analysis, I think it's on an earlier slide, not that this makes a decision, but this informs a decision. So I guess the question partly is, where do you need the most help? Where do you need the most extra help to get the information to move, the two pieces that are remaining with FTAC right now are provider reimbursement and financing. And there's other pieces that go to the commission, but perhaps the provider reimbursement and financing is a more appropriate place. Well, let me make that a question. Is that a more appropriate place for this proviso funding?
That was my initial thinking, Mary, that I was sort of testing with what else is out there that had been done that we may have identified gaps with or would want to further leverage in the absence of, Jane, I tend to agree with you, like in the absence of needing to revisit something or needing an additional scenario from the earlier cost work. To me, the provider reimbursement and financing would benefit the most from actuarial support, as opposed to enrollment infrastructure and governance, which seem more like design decisions to me.
So I've thought, what if, and I'm talking as I'm thinking, what would it make sense to do modeling? Like I know one of the examples was apply sort of different grand sort of structures. I think that was one of the ones. But what if we were modeling like things like, what if you didn't do it through insurance? It's almost like the Medicaid deprivatization, but not limiting it to Medicaid. What if you made certain assumptions about a reasonable percentage of admin? You assumed that you weren't necessarily going to do a risk-based contracting with insurance. What could we assume, like Pam, one of the principals talks about standardizing administration in a whole bunch of different aspects. If we were able to model, what if those aspects of the system changed? Does that help inform decisions around what then you could, like, how does that drive discussions about provider reimbursement? Would that free up funding so that we could pay primary care and behavioral health more without having to pay somebody else less? You see what I'm saying? And if there's this great document that the Center for Health Insurance Reform put out about the complexity of all the administrative middlemen. I saw reference to middlemen, Pam, in the principles. And what if you just took out all of those layers of subcontracting and you simplified utilization review and you simplified claims processing and you simplified eligibility determination? Is it worth it to spend money to think about how much that would free up then to dedicate to other things that you would want to be spending money on? What do people think about that? Is it too mushy?
But only with the groups that we have the ability to do something about, not including Medicare and self-funded plans.
Yeah, I think your point's really well taken. One way to look at it is,
or both ways.
You could say you start with where we have the ability to do something, sort of carve out Medicare for now, just because for the next couple of years or whatever, you're not going to get there. But that's a good question, Vicki. I think it's a really good question.
I can see we did both ways. Sorry. Yeah. Sorry.
Yeah, no, thank you. No, I agree 100%. I think what I would also add is when we look at our plan, and taking into consideration the state of the state where we are right now, especially all the complexities that's going on with the federal government and what the needs of our people are. Where can we say, for example, this? I am a strong believer of we can create something and perfect it, continue to perfect it over time, but how do we deliver something that is quite an improvement of what we have right now in terms of enhancing coverage and accessibility and all of that, but also cutting out the middleman where we can, and kind of experimenting with, can we get away from can we cut this expenses so that we can make this uh you know thing that we've developed is it's affordable and basically sustainable. So I just wanted to add that to the points that is already made, but I agree with everything.
Dr. Kwon-Gret.
Oh, thanks. I just want to add my support to Jane's suggestion. I also like the idea of trying to find administrative savings and cutting out the middleman, so to speak, so that we can use the resources elsewhere for better health. Thanks.
Jane or Joan, sorry.
Answer to both. This is more of a conceptual comment than anything else. In the actual modeling work that we've done, one tool that has been really helpful is getting these dialable tools that can help us as people are, turning up one dial and turning down another, that will spit out kind of ranges of outputs. So I wonder, Jane, I'm not sure that, and Jennifer, how far the 250 can stretch, but I'm thinking out loud about, is there a way to combine these two levers, like administrative simplification and financing, so that you can kind of turn a knob up and down over here and turn a knob up and down over here, and seeing the interaction, I think, is what's the hardest thing to conceptualize or model. So thinking through whether there's some sort of product that could get delivered rather than discrete scenarios that shows the interoperability between, if we move this up and move this down, what spits out, to me, would be really actionable and helpful. I don't know if you can get there with the funding that's been allocated, but that's what came to mind for me.
I apologize. Go ahead, Chair.
I just have a question, because I know Ross and Mary talked about this after last meeting. Do we have a report somewhere, or is there something already created that tells us where healthcare dollars are currently being spent in the state of Washington? Who they're coming from and where they're going? Because I think as we get to figuring out financing and payments, it would be good to know what is not just what the state's spending, but what we're all spending, because this is a change in how the spending is for everybody, not just the state government, right? I think it'd be good to understand, when we did the report for the work group, it said there was like $3 billion savings if you move to universal healthcare, but that's overall the system, not just to the state government, right? And I just feel like it would help to understand if what we're doing is going to fit into the money, if we know what the money is. Does that make sense?
Yes, in Chair Lowe, the Healthcare Cost Transparency Board publishes on an annual basis total healthcare expenditures in Washington State. But the second part of your question of figuring out where that money goes is a little bit more complicated. As part of the cost board's work, we attribute to large provider organizations and with a relatively high confidence level. I'm not sure if that's what you were thinking about, or if you were thinking more about specific service types where that spending is allocated, whether it be primary care or behavioral health or other contexts like that.
Yeah, I was thinking like for for Medicare, I think we have an idea of what the money is coming in for Medicaid, private insurance, but who's paying that? I mean, for Medicare, like the federal government pays for A, people pay for Part B, they might buy a supplement. For Medicaid, hopefully people aren't really paying much of anything, but the state is paying their state share and the feds are paying a certain amount. then what does that look like for private insurance? What, the self-funded plans? Because if we want to have a universal system, we want to bring in those other pieces. And what we build, I think, wants to be a better deal for them, So like if we want to get those self-funded plans to come into the universal healthcare, it has to make sense, I guess.
And we would be
Otherwise, we won't have a big enough risk pool, right?
apologies for interrupting.
Sorry. Yep.
We could bring over from the cost board, perhaps like a per member per month or per member per year, by payer type, like Medicare, commercial, to get a better understanding of the dollars relatively between the different markets, if that might be helpful. And then perhaps we could work with our data folks to figure out a way to dig a little deeper if there's further questions.
I mean, do people think that would be helpful, or because I just don't understand how we're going to figure out what we're financing if we don't know what's currently financed.
Yeah. I mean, have we had that presentation to the commission?
We had, yes, I believe 2 meetings ago, we had our chief data officer, Vishal Chaudhry, present on that. I don't think we spend a ton of time, focusing on market segments, but we do have that data at a state level.
But it didn't have, I think, like the tribal data wasn't really in there.
No.
So I don't know what else isn't in there, right?
And that would be, Pam, that's information that the FTAC would use as well, right?
Correct. That'd be helpful for financing for a lot of things. Yes.
Sorry, didn't mean to stop the conversation.
No, that's a great question.
If there's something we could build on, I don't want to spend a lot. I don't want $250,000 to go through it. I thought maybe a little bit of time could be spent on that, and then the money could definitely go to other things.
And maybe, Vicky, we could just touch base offline and just think of, we can show you what data we have and see if there's anything that jumps out to you that's missing. I would just, identify, like you said, tribal, anything veteran related, probably is not going to be included in our data. So we could identify those groups for you and see if that would be helpful, and then could be happy to circulate that or have a presentation at FTAC or the commission on that data.
Pam, do you think that would be helpful?
I do. I think that maybe doing like a joint, like if it's possible for staff to do like a joint presentation for the commission and FTAC members who are interested. Because some people are more in touch with that data than others, so that's one thought.
And that is great. Yeah, that's definitely doable.
Yeah, I also saw someone. It looks like the report was posted in the chat as well.
And just to level set, just really quickly, what I'm tracking, at least in terms of the ideas that have been discussed so far, is focusing broadly on financing, provider reimbursement, and perhaps as some first steps, identifying a discrete population that we would like to, analyze regarding financing or reimbursement, whether that be, all Washingtonians or, eliminating ERISA and Medicare populations, similar to what we did with Milliman. And then envisioning what changes we're contemplating versus the current system, eliminating TPAs or other administrators. And then perhaps we could put a proposal like this in front of FTAC or the commission soon, as we need to get moving on this to get some some more clarity and feedback, would that be a helpful next step?
Yes.
Yes.
Okay. Okay, well, and Jen, I don't want to steal your thunder, so please correct me. But I think that we can take the information we got today and do some work to put together a proposal in conjunction with setting up an opportunity to hear about the cost board's data call from last year with specific focus on market segments, and just touch base with you, Vicki, to make sure we're noting if we're missing any large markets in our data review.
Okay, but maybe not just me.
Sure.
I feel like I'm the expert on I'm just know some areas.
Yeah, that sounds good. And then I also have a note that the staff can also start to explore the contracting process kind of in the background as we start to refine what the proposal is for the analysis. All right. Well, thank you very much. These, I think, a lot of great ideas were surfaced. There are also some pretty specific ideas, that maybe weren't captured kind of in that roll up. So I think we can go back and kind of pull all of that together, as well as the step about looking at what's in the cost board data set. So,
thank you.
All right, thank you. I'll turn it back to you, Vicki.
Yeah, thanks, Jen. Okay, for our final agenda item today, we'll turn to Ross and our guest, Dr. Mimi McDonald, to talk about 3 design elements: enrollment, infrastructure, and governance. Ross?
Thank you, Chair Lowe. We're going to dive into the 3 design elements that the commission is going to take on next. As Vicki just mentioned, enrollment, infrastructure, and governance. But before diving into the details, I wanted to take a moment to introduce Dr. Mimi McDowell, Executive Director of Oregon's Universal Health Plan Governance Board. We have been working closely with Oregon, and they have been incredibly accommodating and helpful, as we're kind of following in their footsteps in many ways, as they're on a little bit more of an accelerated track. So have just found Dr. McDonald and the entire staff to be really helpful and supportive, and was wondering, Dr. McDowell, if you would take a moment to introduce yourself, and then we'll hop into some more questions and discussion.
That sounds great. Yeah, Ross, thank you so much. And thank you all for inviting me to be here. Yes, I am Mimi McDonald. I'm a physician. I'm the executive director of the Universal Health Plan Governance Board in Oregon. I will say that I've lived in Oregon for 30 years, but I am a Seattle native. So just for a moment, I need to say, yay, Seahawks. Okay. Sorry, I had to get that out. Yes, I have been with the Universal Health Plan Governance Board since April. It has been in operation, this particular phase of the governance board has been in operation since the spring of 2024. We have a little bit more legislative structure about what's expected about a universal health plan, I think, than you do. So I feel like I have a bit of a cheat code as to some of the work that has been put forth for us, but really excited to be here. My background is I'm an OBGYN by training, but then I was local public health officer all the way through COVID. I've worked for a health plan, got a master's in population and health and systems management. And again, just very excited to be here. And I have to say that pretty much my favorite time of the month, we have the opportunity to work with our Washington colleagues and our California colleagues, and it's a great conversation. So back to you, Ross.
Thank you, Mimi. And yes, I enjoy that conversation very much. As I noted previously, this discussion is focused on an overview of enrollment, infrastructure, and governance. And Dr. McDowell in Oregon has already stepped through these design elements, and we thought it would be invaluable to get have the opportunity to ask any questions or discussion about lessons learned from their experience. So if you could turn to the next slide, Audrey. Here, so I guess maybe the next slide. Perfect. Here's our plan for the outstanding design elements. Our goals are to the right for today's conversation, which includes presenting this overview of the design elements, reviewing draft definitions, as we have struggled internally with just clarifying what we mean by enrollment infrastructure and governance, learn from Oregon's experience, and see if there's any volunteers that would like to help us on these different design element work groups. So we're currently on step 1, where we make sure everyone's on the same page about definition and scope. And then we scale down to a work group that meets in between meetings to develop and refine the proposals. As folks have seen in the past, we utilize what we formerly called straw proposals. I think we're now calling summaries for each design element. And then those are worked through the work group to FTAC and then ultimately brought to the commission for their review and approval. And then, next slide, please. The next slide, please. Thank you. Here is the start of step 1 from the previous slide, making sure we agree on definitions. So, some of the following information was pulled from the baseline report and also from other states. So here, enrollment is defined as the process a person completes to enroll in the benefit plan. It can include determining the system that will be used, timing of enrollment periods, and whether they might be supplemental benefits. And so we were hoping to get feedback from commission members today, and any feedback or experience you'd like to share, Dr. Mimi, on this definition in particular.
So my one feedback on this one, and Joan, you should tune in on this one or chime in on this one, is it's not just what system that you're using, it's what we're going to ask of people in order to enroll. So I'm thinking about all the stuff that's going on that was in HR1 and everything that's been in the MBPPs about verification, et cetera, and where you use attestation. And that just seems like a critical enrollment issue. And Joan, your thoughts would be welcome here.
Yeah. Thanks, Jane. I think of I was trying to relate this to our current experience trying to incorporate the federal changes into Health Plan Finder. So I guess the analogy would be, the enrollment portal verification, security, identity proofing, today in Health Plan Finder, which is we consider our enrollment portal, which would be sort of analogous here, just on a way broader spectrum, right? You have 2 million people coming through Health Plan Finder. We do all the ID proofing verification, data collection, and spit out your eligibility. And then you can either go into your free Medicaid coverage for some folks, or you can buy up to QHP, QDP coverage if you want. So for me, that's sort of an analogous, the definition of the process, if we mean it in an all-encompassing way of meaning both what the customer has to complete to enroll and also the verifications, privacy, security, data inputs that need to happen as a collective experience, then I think that makes sense. I think to Jane's point, it's the member has to complete the steps, but you also need an enrollment portal that does the behind the scenes complementary steps so that you end up with a verified enrolled person at the end. So maybe the member and the process is good. Member, it's probably beyond the member, is my initial reaction to that.
That's incredibly helpful. So expanding this to not just contemplate, like you said, the member, but also the system being used in the back end that would be necessary to verify and support the enrollment and make sure that it's valid according to whatever criteria that we have.
I think you got there, Ross, and I think the sub bullets under includes
Okay.
get there a little more. I think privacy and identity proofing are two big components that might data privacy and data collection privacy and identity proofing are two that are kind of critical in our current experience.
Okay, thank you. And
you could even fix it, Ross, you could say the process needed for a member to enroll, and then that'll get you all the way there, I think.
Thank you, Joan. And Mimi, I'm not sure if you had any insights from your experience of trying to define these terms in the discussion that you had regarding it.
Yeah, I think that Joan's point was really well taken about it's certainly not just a member that's enrolling, but I think that taking even a step back, we're fortunate to have a committee that was looking at this, and an operations committee, and really thinking about the, I didn't realize this, you're doing a definition, but about the goal of enrollment. So is your, and I think there's very important part, certainly privacy is a huge part of it, but ease of enrollment, is that a priority? And I think too, and you may have already done this, but exactly, we did eligibility first. Okay, so what defines who is eligible for a universal health plan in Oregon? And that took some doing. It seems like it should be easy because Oregon, we're like, well, everyone should be eligible, but then it starts getting sticky. So nailing down very clearly eligibility first, then enabled us to be able to develop this sort of enrollment process.
Thank you so much. That is a great tip that I think will help us move through this much quicker. And not seeing any other hands up on this, I will move to the next element, which is infrastructure. Broadly, the definition that we're starting with is systems that support care delivery and coordination for universal benefit members. We included a long list of types of systems that might support delivery and coordination, but wondering if that is too high level of a definition such that it's not incredibly helpful, or if we actually need to think even more broadly when we're discussing infrastructure, and welcome any thoughts or comments from Commission or Mimi, if you have any thoughts on this as well.
I just want to jump in with a quick comment. We snuck in a really big one at the bottom of the list, carriers or not. I'm not, just one question to throw out to folks right now. Is this where we make that decision? Is this where the Commission makes that decision? This has come up in the past. Is this the right place to put this question? Do we need to answer this question to go forward with infrastructure? Should it be in a different element? I just kind of wanted to call your attention to it because it's sort of stuck on there on the bottom.
Miriam, I'm interested in what y'all's experience in Oregon is. My analogy is like enrollment would be Washington Health Plan Finder. The infrastructure would be the Washington Health Benefit Exchange in partnership with HCA and OIC, and how we put all the regulatory customer assistance, language access translation, all the pieces around the enrollment portal to help people get through it and manage their, get into their product and use that product. And then the governance is our bipartisan board. So it's probably wildly oversimplifying things, but I would just say in this context, Mary, to your question, if you use something like an online portal that everyone can get in and either get a base benefit or buy up to something else or both, if there's a state administered benefit that you sort of automatically get, and then private products that you buy on top of it, you could see a mashup there. But if you had Dave's not here, so let's pick on Dave. If you had Dave just sort of, take SEB and expand it to 6 million people, and give it to everyone automatically through Washington Health Plan Finder, then his administration of that benefit or a plan being administered by the state would be a huge part of infrastructure in my mind. So that would very much be here, but curious what others think about that.
So, Joan, are you thinking about, right, the administrative infrastructure that you need to support whatever system design is? I mean, in a way, carriers are not, right? Prior authorization, provider contracting, that's it. I think you're asking an interesting question, like those are system design questions, right? And if they don't get answered here, is there any other place to answer them, or is this where we answer them? I mean, they need to be answered.
To me, it's a front end and a back end question, and they're both infrastructure questions. The front end is you need all the infrastructure and support to get someone into the thing and understanding the thing. And then on the back end, you need the state or a carrier, I'm assuming no to TPA based on another discussion about cutting out the middleman, but you need the entity that is, designing the benefit and doing the, providing the services and doing the contracting and all those pieces. So to me, there's infrastructure that's front end and back end. Miriam, tell us all the things.
I wish I could tell you them all. I will say that I think, again, I had a little bit of a cheat code in that in the legislature that helped build up the Universal Health Plan Governance Board, it specifically calls out that the way that providers are paid, that they are paid directly. And even if there were to be, say, for example, a third-party administrator, that TPA could not carry risk. So it's a huge thing, which I'm, again, not sure if you sorted out or not, for carriers or not, but that's sort of the biggest question, because that's probably the biggest question. It's a little bit less to figure out, is the state of Washington going to develop this massive infrastructure, or are we going to use others' infrastructure already? But then the other thing that I would say that was a helpful discussion for us was the discussion around an administrative structure that is centralized versus regionalized. And Oregon has been working with what are called coordinated care organizations, CCOs. So definitely the Oregon Health Plan, our Medicaid administration, for the most part, is very regional. Those payers do carry risk and things like that. So it's very separate. But deciding in Washington, is that what you want? Is that the best way to serve people versus this central one? Was as you said, Ross, kind of like taking a step beyond the specifics of the infrastructure, like all the business of what a health plan does, and really getting to that administrative structure first before getting into some of the more specifics.
Vicky, please go ahead.
For payment and billing, is that to be a part of the universal health care, or is that paying providers and then billing, or is it both?
Great question. When we were trying to think around these, we were trying to envision, what would infrastructure look like under a single or multi-payer system. So both. It's not a helpful answer, but I think we were thinking about both when we were including it here. Just unsure of what direction the commission would go in terms of, it's single or multi-payer.
But the payment is the collection of the premium, for lack of a better word. Or
Yes,
fee.
I guess
both.
envisioning both the collection of the premium, as well as providing reimbursement to providers, if we're discussing more of a single payer system.
I think it might be helpful to separate those out a little
Oh,
more.
sure.
And I do think to Miriam's comment, the really big decision is whether it's a single payer or a multi-payer system, who's bearing the risk?
Yeah.
Right? Is the assumption that you're using risk-bearing entities, i.e. insurance companies, or are you not using insurance companies, but still likely contracting with one or more entities that may also be insurance companies to administer the system, right? So that's when I think of single payer, multi-payer, there's like multiple layers of that.
And so curious, back to, I think Mary had mentioned this initially and Jane commented on it, whether we're reaching a point where it would be helpful to make a determination regarding who's bearing the risk with the system that we're envisioning, such that it might help us inform this infrastructure element and what we need to be accounting for in terms of our proposals, and to the extent we draw it into any future actuarial or economic analysis.
I mean, if we don't have a big enough risk pool, we almost need stop loss or the state to be the stop loss, which I don't.
Yeah, I think lots of those questions will come up as we start thinking through pros and cons of single and multi-payer, and what options would be available to the state with some, maybe a single payer and a stop loss, or I'm sure the verbiage changes, but a similar concept.
Mohammed has his hand up.
Oh, please go ahead, Mohammed.
Yes, thank you both. No, quick question, Mario, maybe Miriam, if you can chime in. Which of the, at least what is proposed right now by the Chair Fiki and which one is the fastest? All I'm interested is getting this system as fast as possible to our people in Washington.
It's a really good question because, I think Pam mentioned before about the importance of incrementalness. If we want to move away from carriers, we can't just like flip a switch and be there, right? So is part of that infrastructure some of that incremental movement or not? I think that's what you're asking, Mom. Are we like
Yes,
just
yes.
going there? Then would this be if we flipped a switch, or is this part of that turning our ship towards universal healthcare and moving incrementally? Because if we look at the work group report, remember it was Model A, which was no carriers, single payer, but through Model B, which is carriers and not single payer. So I think how do we want to deal with that? Do we want to look at what the end result is we want, or the getting there?
Vicky, wasn't
Is
Model
where
B
you
an
go next?
ASO? Wasn't Model B an ASO model? Where
Yeah, like a TPA. Yeah.
yeah.
Thank you, Jane. So if that's the answer, then not carriers, I guess, if that's what we're talking about. I'll say
I like
it
the
too.
idea
It's
of
gonna
Miriam
be
having to
email.
answer which one can get implemented faster, single payer or TVA. I mean, if you're going to be a special guest in this commission, we have to put you on the
Well,
spot.
I will say that if you consider there might be a challenge with flipping a switch and going from however many multiple health plans that there are in Washington, and all of the work that's done there, and then the state of Washington, or through your universal health plan, training training an entire different workforce, or switching over a workforce. I would say that I will just say what the decision that is not completely made yet, but I would say that certainly in Oregon, as I mentioned, in terms of risk, the only risk-bearing entity would be the Universal Health Plan itself, which is an independent public corporation. So it's not the state, it's a public corporation. However, it's still a little bit TBD whether or not there would be working initially with third-party administrators, which, spoiler alert, I probably think is what would happen first. However, ultimately, as Vicki pointed out, like, where do you want to end up? Well, certainly it would make sense to eventually have, a single unified system, but then you have to get there, though, it's true, you have to think about the disruption, you have to think about all the people employed through the health plans and things like that, and how you would be able to change that, or how to utilize those systems. So it's definitely tricky, but it's hard to imagine that just one switch being flipped overnight.
And given the significance of this decision, I don't want to put members on the spot now and make that decision. But even just identifying that is a crucial question to be answered before we come to a recommendation on infrastructure is really helpful, and something that we can perhaps include in where the work group may start. And then, of course, those would come back to the commission for review and approval. So that's incredibly helpful. Not sure if there's any other thoughts on infrastructure, or if I think we can move on to the next element. Again, this is just our overview, and this feedback is incredibly helpful as we're rolling out this work to work groups and giving a little bit more detail on what we're discussing here. So Audrey, if you'd be willing to. Perfect. The last design element we're discussing today is governance, and how we're considering that. Unlike the others, we have somewhat of some direction from the baseline report that was issued prior to the formation of the Universal Healthcare Commission. From the baseline report, they included on governance, the commission will assess whether oversight for the implementation and administration of the transition to the Universal Health Commission will be under an existing agency, a new agency, or a multi-agency structure. Also determine which entity may have a permanent role in oversight and governance of a universal healthcare system, and whether there will be a need to have clear roles and responsibilities for all participants in the process. Wondering if those different points reflect your understanding of what we're talking about when we're discussing governance, or if we need to provide some additional detail on that point. And welcome any thoughts from commission members or Mimi or staff on that.
I'd like to hear from Mimi.
And Mimi, if you have any experience from Oregon to share, this has been an element that's been on all of our minds, and any thoughts that you've gleaned from your experience would be most appreciated.
Sure. We have a plan for governance, certainly, that they're, again, independent public corporation. So that's a huge distinction between so I don't know if that decision has been made yet, state agency versus independent public corporation, or any other type of entity, but where it's housed. So I'm not sure where Washington is at, but if that decision hasn't been made, that would definitely
not been made yet.
So seems to me like that would be the biggest one to start with. because then, there's just, of course, if it's a state agency, there's all kinds of sort of paths to follow. And if it's a public corporation, there's different paths to follow. And so I think like kind of, again, getting back to the sort of the basics, I think would be very helpful. And then it would make a lot more sense than to decide, oh, can we use an existing agency? Or of course, if it's a new corporation, it would be something completely different. So anyway, that's my 2 cents for.
And Mimi, how did you guys end up at Public Benefit Corp? Was it because the exchange
Oh,
is a public-private partnership, so we're kind of a separate entity. We have our state agencies like Healthcare Authority, our Medicaid agency obviously runs PEB, SEB, our 2 million person Medicaid program. So we have HCA who runs gigantic health, coverage programs. And then we have the exchange does is the enrollment portal for both the individual market and Medicaid. And then always is a regulatory body. So we sort of the 3 of us sort of together are covering, 2.5 million people. And the benefits of our public-private structure where we have a bipartisan board that's a little bit separate does allow us to sort of scale up and scale down and get to size. And we were structured in that way in part to just like stand up as the Affordable Care Act marketplace. And we worked with your colleagues so too. So anyway, just interested in the thinking around how you landed at Public Benefit Corporation as opposed to state agency.
Yeah, and I feel bad about this because I don't have all the history behind that. And I mean, Oregon's been working on this for quite some time. So apologies for that. Like I said, for this one, it really was written into the legislation. And I think just part of it, I would say, however, is that because there have been a couple public corporations that are very successful in Oregon, are SAIF, SAIF, which is a public corporation which administers workman's comp. Huge, just incredibly successful organization. Oregon Health Sciences University switched over from being a state agency to a public corporation. And the thinking behind that, I think what you're describing is that public private, in theory, best of both worlds, where you have all the accountability and the transparency for the public corporation, but a little bit more nimbleness with the sort of private side of things. And so, I mean, this is really me probably conjecturing a little bit too much, but I know those have been held up a lot as examples of some of the reason why that's possible. There aren't actually that many in Oregon. There's, I think, a handful only.
Yeah, we're a little unicorny too, but it's sort of like the legislature has oversight in that they nominate and pick the governor nominate and pick our board.
Yes.
And all of our funding comes through the legislature, and there's disclosure and transparency rules. And then there's some flexibility in some of the other pieces. So it's a little more divorced from
absolutely.
So the legislature made this decision once before in 1993 in the Health Services Act. And Pam served on the first Health Services Commission. And so, I mean, Pam, I'm asking you to like scroll so many years back, but if you had to think about sort of the pros and cons of that structure, of the commission structure, would you have thoughts?
So many thoughts, Jane. We didn't get very far. We did mostly planning. So we didn't, but the governance was, it was a commission that was intended to have a lot of power and report it directly to the governor. It was definitely public, under all the rules of public governance at that time. And it was designed to have a great deal of accountability. It was very efficient. Jane, you worked with us a lot, so it was a very efficient structure. It was designed to be efficient because it was expected we would need to move fast, and we did move fast for 2 years, and then came to an abrupt stop. But I think that the other thing that that this exchange has, and that the commission that I was on had, they were explicitly bipartisan, even though the governor in power, the party in power who controlled the governorship, had kind of the last say. They were both very explicitly bipartisan, so that's another thought.
And I mean, I have still in my office on my bookcase the Health Services Act. And Pam, I think the commission did, I have at least one of the commission's reports still in hard copy.
Mm-hmm.
I can't remember whether the commission did one or two.
I have them all. I think there are two. There
you go.
Yeah. It's a real collector's item.
But I guess, Mimi, sorry, this is probably too in the weeds, but regardless of, is it envisioned that the Public Benefits Corporation is going to stand up an entirely new enrollment portal and an entirely new infrastructure? Or are you all leveraging the existing entities you already have through your various state agencies and portals and systems that you have today?
Yeah. We're not quite that far.
Okay.
I would
Okay.
say,
I wasn't sure how far you
think-
were ahead of us. So it's like a marathon ahead or like
No,
I half mile ahead. I don't, it's too much of a-
part of it, I think this is just, acknowledging some of the challenges, certainly with the current, questions, we'll just say, around federal waivers and that sort of accessibility. So our planning structure is really thinking around, of course, building things as we're going, but like the first thought of really being functioning is like 2032, which really isn't actually that far, but it seems like a far way away. So I think that I will just say that there does need to be a lot more work done on that, the sort of, build by, to put it in a very, very basic terms. Question is huge. And again, especially thinking about all of the changes that are happening right now, not to be too geeky about artificial intelligence, but that is revolutionizing what's happening in providers' offices, and and what's happening on the payer side. And so it's a little bit hard to predict. And so, like I said, I think that's sort of in our next iteration. I think there's going to be a huge focus on that. And I think that takes a lot of time and attention to really come up with a workable plan, again, so you don't disrupt the people's jobs and lives and things that are happening right now, how you can do that in the smoothest way possible. But like I said, and eventually, however, get to the outcome that you want, which would probably be less likely to be super piecemeal and really to be more unified.
So are you saying that you made a plan for your universal health system, then you stood up the governance board, and now you're going back through and figuring out again if all that really makes sense to move forward?
Not so much that. I will say, in Oregon, governance board might be a tiny bit of a misnomer, because really they are, again, also like many of you or all of you, except for the staff, a volunteer board. So really still in the very much the planning stages, and then trying to, but sort of in the concrete part of the planning stages, I would say.
Thank you.
And not seeing any additional hands, I think we got a ton of great information out of this discussion. We saw with enrollment, there's some definitional items that we can improve, but with infrastructure and governance, there's a couple foundational questions it sounds like we need to address before getting into the weeds of the design elements. So staff and commission members and FTAC and work group will begin working on those, and we will hopefully have some more news on that in the coming weeks of how we'll start rolling this out and processing how to start answering these questions. And before we move on to the end of the meeting, I just wanted to check in, Mimi, to see if there was any additional thoughts that you had that you wanted to share. This has been so helpful, and really appreciate your willingness to kind of come and let us bat these questions around to you. Really appreciate that flexibility and all the wisdom you shared with us today. And if you have anything additional.
I wish I had more wisdom. No, thank you. It's definitely been a pleasure. And I think, I think it's so important for our states to work together and to talk together and to talk about this, because I think there's a huge benefit in that. And Washington has certainly done lots of things that Oregon hasn't caught up to yet as well. So I think kind of keeping open that communication. I don't have the magic plan though. I'm still working on that.
And just for folks' awareness, Oregon's deadline to have kind of the final plan design, is that in some point in 2026? Is that right, Mimi?
Yes, it is. The due date is September 15th, 2026. Now, that doesn't mean it won't completely change after that as well, but we do have a deadline, and that is it. And I am a fairly harsh taskmaster. So although people thought perhaps that we would extend it, I said, no, we will be done. So we'll be done in one way or another.
Okay, that's fantastic.
So your design is this fall and your go live is 2032. I like it.
We give ourselves a little wiggle room.
Yeah, I like it.
Well, excellent. Thank you all for that really helpful discussion today. Just want to check, Mary, did we cover all the information that?
Yeah, I think we're good. I think we can, I'm not sure what's on the following slides. I should know. Try to get our enrollment group together.
Yes, I think that is our last step with this discussion, is seeing if there's anyone interested in volunteering to be on, is it the 3 boards, Mary, or work groups, governance, infrastructure, and enrollment?
I think today it would be great to get people in place for enrollment.
Okay.
And then I know we have some of the really big foundational questions for infrastructure and governance. And I'm thinking and talking at the same time, which is, do we take those back and try to frame up those questions and figure out what those questions are? Or do we ask for people to help us go through those questions? Which was very much a non-answer to your question.
Well, I would certainly open that up to commission members. I think the question that Mary posed is, would it be helpful for staff to come back with some more discrete, laying out this question with infrastructure about what type of risk bearer we want, and with governance in terms of what governing entity are we envisioning? Would it be helpful to have that come back as a topic at a commission meeting or an FTAC meeting, or would the preference be to have staff put out proposals and have folks go from there?
I think it's always good to have something on paper to react to, but I'm also mindful of when these pieces are supposed to be done. What's the timeline?
Trying to remember, because we did put together a timeline. I'm going to have to revisit that because I'm not exactly sure of the dates, but I think what we thought about was we staff can only manage so many of these work groups and projects at once and actually make progress with all of them. So right now there's provider reimbursement with FTAC, a work group that's ongoing, the work that Pam described. And then we were thinking we would do an enrollment group. Yes, enrollment with the commission, and then also be working on the OIC funding. And then when you get through provider reimbursement and enrollment, FTAC picks up financing and the commission picks up the next 2. And I think Jen is on the call. So you can, let me know. I think that takes us through the end of 2027. Jen, is that what we said?
I'm just looking at it right now. Yeah, we had enrollment starting in February, and ending at the end of September. And then it looks like the infrastructure and governance were right now slotted for September, a September start, and then ending around Q2 2027.
Which is a very draft,
Yeah, very
which
drafty.
is our draft thinking on it to see how long these things would take and to see how much we could stand up at once.
Well, just thinking back to that question of perhaps asking commission members if they'd be willing to participate on enrollment work group. Maybe we're a meeting away from that. As we had discussed, we might need some decisions prior to beginning the enrollment discussion. So maybe it'd be better to put our eggs in that basket of getting those questions regarding infrastructure and what type of single payer, multi-payer, to get that information before going into enrollment. Does that make sense to folks? I would envision that would look like staff coming back with some proposals related to the question regarding infrastructure and the question regarding governance, single multi-payer, and what type of governing entity are we recommending that those questions would need to come back first.
Yeah.
Okay. I heard a yes from Jane. If there's any strong opposition to that, please let us know. I know these are kind of the $1 million questions that are part of this process, so I would hate to rush through those, but really grateful for Mimi at kind of pointing that out, that those might be roadblocks to us progressing on these design elements if we don't address them. So thinking this may be the appropriate time to start asking those questions. Excellent. Mohammed, please go ahead.
Thank you. No questions here. I really wanted to commend my fellow commission members for all the work. We're almost there, and wanted to commend you all for the amazing work that you do, even though the number you guys are short-staffed. Is there anything we can do, like sending letters to legislation or anything to bolster your numbers or your capacity? Is my question. I don't know if that is appropriate in this call.
No, we love that question. Thank you, Mohammed. I think what comes to mind is I imagine we are going to be forming work groups around some of these design elements soon, and your participation along with any other commission members would be incredibly welcomed, and that helps us so much and really speeds up the process for us if we're able to work in between meetings. So that would be what I'd ask folks to consider, and think we're maybe a meeting away from setting up those new work groups, maybe a meeting or two. So that would be my thought. I don't know, Mary, if you have any other ideas.
I just wanted to add a little bit about the work groups and the structure. We've had these in place with FTAC, going back to the Milliman work that was done last year. We had a work group working on that. We've had work groups working on other things. So we've kind of developed a system and a cadence that's working. So I think we can pretty easily translate that to a commission workflow. So we have a good idea of what we can get done between meetings. The work group works on it, circulates it to the larger body, works on it some more, then maybe, the FTAC work goes to the commission. So I think once we get around to forming those smaller work groups, we can get going pretty quickly because we have the experience of doing this now. So FTAC, thank you, FTAC folks. I know there's a bunch of FTAC people on the call. Thank you for helping us refine that and figure that out.
And Mary, sorry, one question for you, and I apologize for this business being done in the meeting. Are you envisioning for the questions that we've identified relating to infrastructure and governance, those going to FTAC first, or are those going to go directly to the commission for their input? Do they need FTAC's initial recommendations?
For infrastructure and governance, my hunch is it would come back to the commission without necessarily making us stop at FTAC.
Okay.
Unless, I don't know, Pam, you're still on the call, unless you think that there's something that should be going to FTAC in the meantime.
You kept me on a pretty short leash for this meeting. I would really leave it to the commission if you want to consult with us. There's expertise on FTAC, and if you want an opinion on those topics, but I think they were not ones that naturally belonged in FTAC. But I also think the back and forth can be really helpful. So if you need us, you should direct questions or work to us on these topics.
Yeah,
I completely agree with Pam. I think the more perspectives we can get, especially from FTAC, who's been giving concentrated thought to this for a long time, would be of value.
Thank you. And Joan put something in the chat. Is it envisioned that anyone from FTAC is on the enrollment infrastructure or governance work groups?
I think we were all saying the same thing.
Yeah,
so
yes, if they want to be. Yes, I mean, that can work as well.
Because we can only have 3 commissioners, right? Otherwise it's no.
I think it's more than
No,
3, isn't it?
I think we could
No,
have.
a quorum is 7. Never
Yeah.
mind. Sorry, I do have a migraine, so I apologize for being kind of dense today.
Well, that's probably a good point for us to head towards wrapping this meeting up. Just want to, again, thank everyone so much for this input. I think we made great progress today and given us a ton of direction of these next really big steps that we have in front of us. So again, thank you. And I will hand it to you, Vicky, to close us out.
All right, and right on time. Recording of and resummary of this meeting will be posted shortly on the HCA's webpage for the commission. Our next meeting is off cadence, so pay attention. It is Thursday, April 30th from 2 to 5. And I look forward to seeing you all there. Might see you before then. And so the meeting is adjourned at 5 p.m. Thank you, everybody. Have a great evening.
Thank you, everyone.
Take care.
Thank you. Take care.
Take care, Mohammed. Safe travels.